today's talk, we are going to discuss about applied renal physiology, the science version, assistant professor in Department of Pediatrics, Chennai. This is going to be the outline of the talk, and over the next 15 to 20 minutes, we'll look at various applied aspects of physiology that's produced handled. Okay, we have about 1 million nephrons in each kidney, and kidneys perform a very important role of excretory function. They remove the nitrogenous waste. They are very important in the acid-base, electrolyte, and water balance. These are the chief day-to-day activities of the kidney in maintaining good internal milieu with proper homeostasis. Apart from having excretory role, which I'm going to discuss in the subsequent slides, kidneys also act as an endocrine organ. They secrete few hormones like 1-alpha hydroxylase, which is important for the final activation of activated vitamin D3. They also secrete renin, which plays a very important role in the renin-angiotensin-aldosterone axis. And they also produce erythropoietin, which glucose acts on the red blood cells in the marrow to increase production of red blood cells. Now, they are also the target organs for ADH, thyroid hormone, and aldosterone. Glomerular filtration is going to happen here, and tubular reabsorption as the solute passes across the various tubules, and then some amount of what is called tubular secretion, wherein certain substances are secreted into the tubules from the peritubular capillaries. So glomerular filtration essentially means when the blood flows from the renal artery, it passes through the arcuate arteries, reaches the radiate arteries, and through this, it is now going to enter through the afferent arteriole, passes through this glomerular area, which is the network of capillaries, which increases the surface area for exchange of substances. Substances which are very small would easily diffuse across this and enter the urinary space. And substances which are tightly protein bound would not leave this, and then they pass on through the efferent arteriole, which then goes back to the venous circulation and get connected to the renal vein ultimately. So this is where glomerular filtration really happens. There are a lot of factors which affect the glomerular filtration. The chief ones being what is the renal blood flow. If there is increased renal blood flow, more blood is going to go through the afferent arteriole, and more filtration is going to happen. So renal blood flow plays a very important role in affecting how much is the glomerular filtration. The other two important ones which are physiologically controlled are the diameters of the afferent and the efferent arteriole. If we increase the afferent arteriolar diameter by decreasing the arteriolar resistance, there's going to be more blood flow and hence more glomerular filtration. And the converse will happen if the arteriolar resistance and the afferent arterial resistance increases. When the afferent arterial resistance increases, there's going to be decreased blood flow across the glomerular, so glomerular filtration is going to be reduced. Now the reverse happens in the efferent arteriole. If we increase the efferent arteriolar resistance, there's going to be resistance to flow of blood across to the efferent arteriole. So more of it is going to get effectively filtered across the glomerulus. So in day-to-day practice, NSAIDs and the calcineurin inhibitors like cyclosporine and tacrolimus, they have nephrotoxicity in one way by affecting the resistance of the afferent arterioles. So they decrease the afferent arteriole diameter acutely. This leads to reduced blood flow and decrease the glomerular filtration. This is one mechanism of nephrotoxicity proposed by these two drugs. And ACE inhibitors play a role by increasing the resistance of the efferent artery. Apart from this, sympathetic stimulation also can affect the way glomerular filtration can happen. So this diagram again shows very clearly how we modulate through the afferent and efferent arteriole, how we modulate the glomerular filtration that happens subsequently. So glomerular filtration rate, or called the GFR, is most commonly used marker for assessing the renal function. So GFR is very variable throughout the entire age group. It is about 20 mL per 1.7 centimeter square per minute at birth, and steadily reaches the adult value of about 120 mL by about 2 years of age. Remember, GFR is a very dynamic variable. There is a lot of inter-individual and intra-individual variabilities. Due to to differences in age, differences in gender, the body size and habitus, the muscle mass, what is the hydration status, what is the activity of a particular person, and what is the level of protein consumption that person has had. So all these have an effect on the glomerular filtration rate. So we all must be aware with the fallacies which serum creatinine pose to us in the day-to-day practice. Creatinine levels are unreliable until about 50% of the nephrons are affected. And creatinine value is affected by a lot of non-renal factors like what is a nutritional status, what is a fluid status. Patients who are fluid overloaded. So we have what's called the corrected creatinine values, where we correct them for fluid overload, and then you see what is the creatinine values. The values are really different. The muscle mass, the person who is well built and has a good muscle mass will have a higher creatinine level. So these things also affect the serum creatinine level apart from the steady state kidney function which we is trying to measure. Also, remember, creatinine gets secreted through the kidney. So any medication which interferes with the secretion of creatinine into the kidneys will affect the serum creatinine levels. So in day-to-day practice, this we commonly see when we use trimethoprim, that is Septran, which blocks the secretion of creatinine. Once less creatinine is secreted into the urinary space, the serum creatinine levels go up. The patients who are concomitantly on Septran, cimetidine, or salicylate for some other reasons, you may have a transiently higher level of serum creatinine. This is not because of renal dysfunction, but then because of impaired tubular secretion of creatinine during the increase of availability of creatinine. Also, creatinine increases following red meat intake. So there is increased protein intake that will bring to increased production of creatinine, and that will be reflected upon as high creatinine levels. Also, the assay you use to measure creatinine will influence the serum creatinine levels. We have moved on from what was the earlier creatinine measurement by the assay method to the more recent isotope dilution mass spectroscopy method, the IDMS method, which is now considered the gold standard. But most of our labs, what we generally have is an enzymatic method, wherein we are estimating creatinine through the enzymatic methods, and then post-measurement, we have some conversion formulas which will help us to trace this value to the IDMS method. So post-measuring, the labs themselves have a correction formula which is then incorporated into the estimated value to give the creatinine which is reference to IDMS. So many times if we get in your report, you can see that creatinine value within bracket they are written trace to IDMS. That means the creatinine levels is not traced to IDMS method. So that is considered the gold standard and the best way to assess creatinine. Now these methods have been evolved over time. This is just to refine and measure only creatinine, because the previous methods used to measure creatinine because of other interfering substances, other chromogens which look like creatinine. Earlier, the biggest problems were with bilirubin and ketones. They would influence the way creatinine is measured. Whenever the hyperbilirubinemia is there, the serum creatinine levels were reported to be much low. And then once you correct them for bilirubin, creatinine levels go up. So to prevent all this, now we have made more purified techniques wherein IDMS is considered the gold standard. Another important concept in glomerular physiology is the tubuloglomerular feedback. Now, this feedback simply is trying to give a feedback to the own kidney, the own nephron. Whenever there is an increased delivery of sodium distally, the body tries to realize that so much is now getting wasted. So let me reduce the glomerular filtration rate. It goes and adds to the afferent arteriole and orders it to reduce the blood flow. So this is in short about tubuloglomerular feedback. So what literally happens is whenever there is increase in glomerular filtration, there is going to be more sodium delivered through the proximal tubule. Most of it gets reabsorbed here, some and the loop of Henle, and a part of it reaches the distal convoluted tubule. So the part of the tile, which then goes on to become the distal convoluted tubule, there's specialized cells here called the juxtaglomerular apparatus here. Macula densa cells are there. Now these cells will sense the increased distal delivery of sodium and chloride. The increased chloride that was found here is then taken up by the macula densa cells, increases the production of adenosine, which increases the intracellular calcium. Now, this will lead to smooth muscle contraction of the afferent arteriole, leading to vasoconstriction and decreased afferent arteriolar blood flow. Once the arterial of the afferent arterial diameter contracts, decreased glomerular filtration is going to happen. So whenever there is more sodium delivered distally, the body will try and form a feedback and inhibit the blood flow into the afferent artery. This is considered a very protective mechanism the body is doing. So this are the important applied aspects of glomerular physiology we have seen. Now we'll go and look at the tubular reabsorption and tubular secretion aspects of the kidney. The tubular reabsorption is a very robust mechanism. Remember, majority of what is glomerulally filtered is totally reabsorbed by the various tubules that we see. This mechanisms, the proximal tubule, the loop of Henle, the distal tubule, and the collecting ducts together help us in reabsorbing most of whatever is getting filtered across the glomerulus. So this is through active and passive transports. So there we have separate transporters for each of the substance which is going to get reabsorbed. So we have separate transporters for sodium, potassium, calcium, magnesium, chloride, bicarb, and water. And majority of the substances are reabsorbed at the proximal convoluted tubule. They have dense mitochondria and huge brush borders, which increases the surface area and the effective absorption of almost all of these agents. Now, apart from this, glucose, amino acids, protein, vitamins are also reabsorbed maximally at the proximal convoluted tubule. Now, once then passes the glomerular filtrate, then enters the loop of Henle. In the thick ascending limb, we have the NKCC, sodium potassium chloride transporter, which is the site of action of our dilute diuretic furosemide. Now, this is an important role by reabsorbing about 20 to 25% of sodium that comes to this spot. This is then actively reabsorbed at this point here, and subsequently the fluid which goes down the line will contain less of sodium and chloride, which are then reabsorbed in distal convoluted tubule by NCCP, sodium chloride cotransporter channel, which is the site of action for thyroids. Now, distally, as the blood goes forward, the urine goes forward in the distal convoluted tubule and the collecting ducts. Now, we have active secretion of potassium and H+. Now, this is under a control of aldosterone. So, this part of the nephron is called the aldosterone sensitive nephron, wherein under the influence of aldosterone, the body is able to throw potassium in exchange for sodium, which it reabsorbs. So body at any point will try to reabsorb sodium preferentially over any other molecule. It is ready to reabsorb sodium and then throw in potassium or H+ through the various channels available, which we just see to secrete these things and then reabsorb sodium. So this is an important secretory function of the kidneys. Now, various parts of the nephron are now controlled by the numerous hormones, as illustrated here, like how we saw this is the aldosterone sensitive part of the nephron, and this orange one means it is the effect of vasopressin. This is where water reabsorption is tightly regulated. Although majority of water is going to be reabsorbed in the proximal convoluted tubules to aquaporin in one channel, that is not regulated. The distal ones here is where the final reabsorption is totally regulated by the effect of vasopressin or the antidiuretic hormone. No. This area is also then controlled by angiotensin II, and the parathyroid hormone affects the amount of calcium and phosphate which is reabsorbed and secreted in the proximal and distal convoluted tubule. So now these are the three important functions of the kidney. First, we saw glomerular filtration. Next, we saw tubular reabsorption. And third is what is tubular secretion. Now, let's see important exocrine functions of the tubule. I will try and describe the various channels and how each of it acts. Now, sodium handling by the kidney. Now, this is a beautiful diagram which is in nutshell trying to show you at various parts of the kidney what receptors are acting. So once the glomerular filtration happens, whatever enters the proximal convoluted tubule, 60 to 80% of this is now, sodium is now going to be reabsorbed at the proximal convoluted tubule. Now you can really see that as it crosses the proximal convoluted tubule, the majority of sodium which is now there in this fluid is reabsorbed. Now this reabsorption happens through a lot of receptors, which is the sodium amino acid receptors, SGLT2 is the sodium glucose co-transporter, sodium acid exchanger, and so on and so forth. So all these together contribute to about 65% of the absorption of sodium in the proximal convoluted tubule. Now, once the sodium goes beyond now, here is where the loop of Henle, the thin descending limb followed by thin ascending limb followed by thick ascending limb. Now, thick ascending limb is the site for the NKCC channels, which is where the loop diuretics are. So in this NKCC channel will help reabsorb 1 sodium, 1 potassium, and 2 chloride and push them into the blood circulation through this NKCC channel. Now this NKCC channel is therefore responsible for about 20% of distal sodium reabsorption. Now once the sodium has crossed and is about to reach the distal tubule, about 80 to 85% of sodium is already completely reabsorbed from the proximal tubule and the thick ascending loop of the loop of Henle. Subsequently, we have very little amount of sodium which needs to be reabsorbed. Now this, once it enters the distal convoluted tubule, we have the sodium chloride co-transporter which will take in sodium and 1 chloride to the blood from the tubular lumen. And this is where the thiazide diuretics are. This is where the thiazides are. When they inhibit this channel and cause natriuresis. So about 10% of the sodium which is reabsorbed at the distal tubule, and then we inhibit it if you end up using thiazide diuretic. And finally, the distal control of sodium is now happening in the cortical and collecting ducts and outer medullary and inner medullary collecting ducts, chiefly through these channels. What are these channels? This is the ENaC channel, which is inhibited by amiloride and triamterene, where sodium is reabsorbed. Now, this is totally under the influence of aldosterone. We also have mineralocorticoid antagonists. So if you give spironolactone here, it is going to inhibit this channel and then prevent sodium reabsorption. So the distal convoluted tubule, the late aspects of DCT and the collecting ducts, we have the ENaC channel and the mineralocorticoid receptors, both of which can get inhibited by amiloride and spironolactone, which will then inhibit the distal sodium reabsorption. So now these are the various mechanisms by which sodium is getting reabsorbed and total reabsorption happens in the body at various levels of the kidney. So the applied aspect of this is to understand about fractional excretion of sodium. Now, fractional excretion of any substance is urine of that substance upon the serum of that substance, and you index it to creatinine, as creatinine is constantly excreted throughout the day, so as to prevent fallacies and measurement. You wanted to index it against a standard agent like creatinine, which is excreted at a constant rate throughout the day. Now, a value which is less than 1% of FeNA suggests that it is pre-renal AKI, and another value exceeds 1%, then that is when we call it intrinsic AKI or the acute tubular necrosis. Now, we should all remember that there are some prerequisites that before FeNA is measured, patients should not have received any diuretics, patients should not have been on any IV fluids, because these are all important confounders and they'll affect your estimation of FeNA. If your patient has already received 1 shot of furosemide, subsequent to that, it's really not correct to measure the fractional excretion of sodium, because now this is all altered by the effect of the diuretic. Till the diuretic effect weans off, you really can't measure fractional excretion of sodium and then guide whether it is pre-renal or intrinsic renal AKI. And to overcome this, we have another fractional excretion of what is called the fractional excretion of urea, urea, wherein instead of sodium here, you can just replace it by urea. So you urine urea by serum urea and then index it for creatinine, and then you get the fractional excretion value. A value less than 35 to 40% suggests pre-renal AKI, and this may be used in reference to fractional excretion of sodium whenever a patient has received any diuretics to help you identify whether this is pre-renal or intrinsic renal AKI. And this is about the applied physiological aspects of sodium. We're moving on to the potassium handling by the kidney. Now, 70 to 80% of whatever potassium which is filtered across the glomerulus is going to be reabsorbed in the proximal convoluted tubule. Now, this is through these channels. Whatever through the sodium potassium ATPase, the potassium chloride channels, potassium is going to get reabsorbed into the bloodstream from the urinary lumen here. Okay. The remaining 20% is now reabsorbed at the thick ascending limb of loop of Henle. Now, this is through the NKCC channel here, which as we just saw, along with sodium and 2-chloride, it also reabsorbs potassium. It takes in potassium through this MKCC channel. And then in the apical membrane, where we have the sodium potassium ATPase and the KCC channels through this, potassium is then subsequently sent into the blood. So this is the mechanism by which potassium gets reabsorbed at the tal site. Subsequently, the distal convoluted tubule and the collecting duct have variable potassium reabsorption, and this is principally through the aldosterone sensitive distal nephron, all of which is totally dependent on the effect of aldosterone. Whenever there is increased level of aldosterone, body will try to reabsorb sodium through the ENaC channel and throw in potassium through the ROMK channel and BK channel. Through this, potassium gets secreted into the urinary space. So increased effect of aldosterone will increase the throw of potassium through these channels and lead to hypokalemia by increased excretion of potassium into the urinary lumen. This happens at the principal cell, and the intercalated cells, we have the alpha intercalated cells, beta intercalated cells. The alpha intercalated cells are meant for acid regulation. Here we have the H plus K plus ATPase, which will help in taking up potassium if you throw up H plus ion in the intercalated cells, which is along the distal part of the collective duct. So these are the various mechanisms by which potassium is handled by the kidney at various levels. The applied aspect of this is to understand about what is the transtubular potassium gradient, which gives an accurate estimate of the aldosterone bioactivity in the late distal convoluted tubule and the cortical collecting duct. So in 80 kg, now beyond this point, the late DCT and the cortical collecting duct, no further reabsorption of other electrolytes. So potassium is the last thing to reabsorb. Beyond this is the action of ADH, which will help in reabsorption of water. So to index to account for that, we use the serum upon urine osmolality to formulate for this, and then we calculate the fraction excretion. So you do the urine potassium upon serum potassium, and then you index it with osmolality to arrive at what is called the TPKG, the transtubular potassium gradient. And normally this value is between 6 to 12. So whenever in the setting of hyperkalemia, the TPKG has been found to be useful. In the setting of hyperkalemia, you expect TPKG to also be high. But if the TPKG remains low, less than 6, now you want to know whether this is because of hypoaldosteronism or because of intrinsic renal resistance. Now, to differentiate between these two, you go ahead and give one oral loading of fludrocortisone, about 0.05 milligrams. Now, the moment you give fludrocortisone, if there were hyperaldosteronism, which was the cause for this low TPKG, giving this would correct the TPKG, and TPKG would rapidly rise to more than 6 within the next 2 to 4 hours. However, if it was because of intrinsic renal resistance, the TPKG value will remain unchanged and will continue to remain less than 6 even in the face of hyperkalemia. Now, this then tells us that hyperkalemia in this particular patient is because of intrinsic renal resistance and not because of hypoaldosteronism. So this is the applied physiology of using TPKG in clinical practice. Okay. So the third most important mechanism is acid-base regulation. Now, this is a rough values wherein it tells you the bicarbonate reabsorption at various segments. We see that about 80% of bicarb is now going to be reabsorbed at the proximal tubule. Now, how does this happen at the proximal tubular level? Whatever bicarb which is not filtered and enters the urinary space here combines with H plus to form H2CO3. This is then dissociated into water and CO2 by the type 4 carbonic anhydrous which is present in the membrane. We also have a type 2 carbonic anhydrous which is present in the cell. Now, these two have different pK, pharmacokinetics and dynamics of the enzymes, because of the variable rate at which they help in dissociate within and outside the cell. So this H2O and CO2 then subsequently CO2 can easily diffuse, and we saw that water is also freely permeable to the aquaporin 1 channel. Both of them enter the cell. Inside the cell, they acted upon by the Ca2 isoform. This then forms H2CO3 and a H plus N bicarb. This bicarb then gets reabsorbed into the blood through these bicarb transporters NBC, and also has sodium bicarb exchange. Through this, now bicarb gets salvaged from the urinary space. So whatever bicarb came in the urinary space is now reabsorbed in this format, and from here it is entering the circulation. So 80% of bicarb which enters the urinary lumen is then reabsorbed at the proximal tubule through these mechanisms. Now the remaining part of it is through the thick ascending limb of loop of Henle, the distal tubule and the cortical collecting duct. The distal part of this is mediated through this. But most of TAL and DCT also has similar mechanisms of reabsorption. where bicarb combines with H plus acted upon by carbonic anhydrous, leads to the formation of water and CO2, which then are reabsorbed into the cell, and within the cell acted upon by the other isoform of carbonic anhydrous, leading to the production of bicarb, and when the bicarb subsequently gets reabsorbed into blood through different bicarbonate transporters, which are not really NBC. NBC is predominantly seen in the proximal convoluted tubule. Distal tubule, there are other channels which are reabsorbing bicarbonate. Whereas in the intercalated cells, the alpha intercalated cells, the mechanism is slightly different. Here, the same thing which forms, which acted upon by the carbonic anhydrous type 2 isoform, leads to formation of bicarb. This bicarb is then getting reabsorbed through the bicarb chloride transporter. So this transporter is slightly different in this part of the method. So now this is how most of the acid bicarbonate gets reabsorbed, and H plus is now thrown into the circulation. So remember, this H plus ATPase is the main site of action where distal RPA diseases with distal RPA are because of defects in this gene channel, wherein H plus throwing into this with the secretion of acid here is now defective because of defective this channel, and this leads to formation of distal RPA, which you are just going to see in a minute. So to differentiate between proximal and distal RPA, we have two important tests, the fraction expression of bicarb and mu minus BCO2. Like any fraction expression, we are trying to look at the fraction expression of bicarb and say if the primary defect is bicarbonate urea or defect in acid secretion. If it is bicarbonate urea, which is the mechanism in proximal RPA, you expect that a lot of bicarb is now getting wasted in the urine. So whenever we calculate the fraction expression of bicarb, it is going to be more than 15% in proximal tubular acidosis. The classical example is cystinosis, canonical, etc. However, in distal RPA, bicarb reabsorption is not effective. It is only the distal acidification which is defective. Hence, the fraction expression of bicarb in distal RPA is going to be less than 5%, as you would see in a normal patient. Okay. Now, another important concept which we are trying to understand here is U minus B CO2. So basically, urine PCO2 is considered to be a sensitive marker of distal acidification. Only if the distal acidification mechanisms are intact, you get more CO2 in the urine. So if the distal acidification mechanisms fail, H plus is not getting secreted, then PCO2 formation is also affected. Hence, a low urine PCO2 or a low U minus B urine minus blood difference really suggests that the distal acidification mechanisms are affected. And this is the mechanism in distal RPA. Hence, we see that in distal RPA, when the urine CO2 is going to be much less, and the difference in urine minus blood is either going to be negative or less than 10. Whereas in proximal RPA, the U minus BCO2, the distal acidification mechanisms are intact, so PCO2 formation is not really affected. So the urine values are much more than blood, and the U minus BCO2 difference is definitely positive and is almost always more than 20. So this is a U minus BCO2 simple test to perform. This test helps us identify whether it is a distal RPA or proximal RPA. Now, the important thing to remember is before performing U minus BCO2, we should really ensure that the urine pH is already more than or equal to 7.5, and the serum bicarb is more than 22. Only once you fulfill these two conditions, then you measure the urine PCO2, and then you find the U minus B difference and then calculate and see what is the value. A value which is more negative or less than 10 suggests this is distal RPA. Apart from this, the other things which you can see to differentiate whether it is proximal or distal is look at other wasting. So there is phosphaturia, there is amino acid urea, there is glucose urea, there is beta-2 microglobinuria. All these suggest that it is probably proximal RPA rather than a distal RPA. Now, another important physiological concept here which you need to know is what is called the FF test or the furosemide fluorocortisone test. Now, the basic physiology behind this is prestigious. So, whenever you give furosemide, it is going to inhibit the NKCC channel. So, sodium, 20% of sodium reabsorption which is happening through TAL is now affected. So, more distal delivery of sodium to the distal convoluted tubule. We just saw that body preferentially reabsorbs sodium in exchange for anything and everything. So, sodium will get actively reabsorbed and it will throw out H plus and K plus. So this is the mechanism by which hypokalemia and alkalosis happens when you give diuretic, like furosemide. So whenever all the sodium is getting reabsorbed and H plus is thrown. Whenever H plus is thrown into the urine, it is going to make the urine more acidic, right? So what happens? So whenever you give furosemide, you expect that the urine becomes acidic. So this is the normal mechanism which anybody would expect if HSCC channels are working. Okay. Now, fludrocortisone, what it does is, because the distal H plus, as we saw, that this acidification, throwing of H plus and K plus is aldosterone mediated. We just want to not get the effect of low aldosterone interfere with our acid. So we just give them fludrocortisone and keep them breath fluid. Now this fludrocortisone will increase the avidity of distal sodium reabsorption, so that whatever sodium is now not reabsorbed at the tal level is avidly reabsorbed at the distal level. Whenever sodium gets avidly reabsorbed, as a consequence, it's just going to throw H plus and K plus, which is what we are really trying to measure here. Okay. So the test involves administering 2 milligram per kg of furosemide with 1 milligram fludrocortisone, and then you look at the urine pH every hour and look at the potassium. Normally, what happens, as we just saw, whenever you give, the moment you give furosemide, you are going to make the urine more acidic. So the urine pH will fall and become less than 5.3. Whereas in patients with distal atrophy who have distal acidification defect, this H plus is not being thrown into the urine. So the urine never becomes acidic. So the urine pH is always more than 5.3 in patients with distal atrophy, suggesting that there is acidification defect. So if this is the form of incomplete RTA, when you evaluate patients who present to you with stones, and you want to look at the etiology for the stone, and if you're suspecting that RTA is the cause for distal atrophy, incomplete distal atrophy is the cause for stone in this patient, we do what is called the FF test. Simple test, you just give one shot of oral furosemide and oral fludrocortisone, and then keep measuring the serial urine pH in the patient. The pH drops to less than 5.3, that means there is intact acidification mechanism. The pH does always remain more than 5.3, that means there is a acidification defect and the patient may be literally having incomplete distal atrophy, which can be the cause for stones in that particular patient. Moving on, this is what this TMP-GFR. Now, normally the phosphate levels are influenced by the serum creatinine level, and they are also influenced by what is the GFR of the patient. So, fractional excretion of phosphate can then be helpful in, by doing this TMP-GFR, we are evaluating whether there is renal phosphate wasting or not. So, like any other fractional equation, we calculate fractional excretion of phosphate. So, urine upon serum phosphate and you index it for creatinine. You get what is called the fractional excretion of phosphate. Now, 1 minus fractional excretion of phosphate will give you what is the tubular reabsorption. And this is what is called TRP. Now, once you get a TRP value and you have a serum plasma, you plot them in what is called the Walton Bijovet nomogram, wherein you take the serum, in this patient, for example, the serum plasma phosphate is 1.5 milligram per dl. You found out that the TRP is 60. Now you connect these two dots and extend the line to this curve. Wherever the line fits, that is what is the TMP-GFR of that particular patient. In this patient, the TMP-GFR has come down to be 1. Normal TMP-GFR is somewhere between 2.8 to 4.4. So this clearly suggests a low TMP-GFR, which means there is renal phosphate wasting. So this, by this mechanism, any patient who has low serum phosphate, if you want to identify the source of this low serum phosphate is because of renal phosphate wasting or not, one would calculate TMP-GFR and really identify a low TMP-GFR means patient is having renal phosphate waste. Okay. Okay. So moving on to the last physiological aspect which we are trying to cover today is water handling by the kidney. So as we just saw, 70 to 80% of water is going to be reabsorbed at the proximal tubule through the aquaporin 1 channels, and remaining 20% happens in the descending limb again through the aquaporin 1 channel. 90% of water freely reabsorbed through aquaporin 1 channel. And this is not chiefly regulated. So what is regulated in water reabsorption is the distal 10%, which is now influenced by the collecting duct. And we have the aquaporin 2 present in the principal cell, which play a very important role in reabsorption of this remaining 10% of water. So if you look at this figure, this distal part, when it is zoomed, we find that the collecting duct has principal cells and intercalated cells. This green is the intercalated cells, and this is the principal cell. Now this is the urinary lumen, and this is the blood component. So what happens is aquaporin channels are present in the urinary aspect of the principal cells. Now, aquaporin channels, when they are present in the apical membrane, water can then reabsorb through the aquaporin channel. Okay, so normally aquaporin channels are produced in the cell. Then they, through the effect of vasopressin, whenever vasopressin acts, these aquaporin channels which are present in the cell membrane intracellularly, which are then get incorporated into the cell membrane here. Only the aquaporin channels are embedded into the cell membrane, water can get reabsorbed, and then further reabsorption into the basolateral membrane happens to the aquaporin 3 and 4 channel. So if there is aquaporin 2 channel, it fails to get incorporated into the lumen, then no water reabsorption happens. So this trafficking of aquaporin is now chiefly mediated through vasopressin. Hence, the role of fractans as a new class of diuretics where we are trying to adjust the way in which aquaporin channels get incorporated. Another important physiological concept here we need to understand is what water deprivation is. So this is the normal urine osmolality, and assuming that the urine osmolality is 200 for a person. Only when it is at this range, you would suspect that the patient may have one of these defects. Now, once the patient has a low urine osmolality, then what you try to do is you try to deprive them of water. The moment you deprive a patient of water, the osmolality is going to shoot up very nicely in a normal individual to up to a ceiling of about 1000 to 1200 millimoles per kg. So what was 200, moment you started depriving the patient, over the next few hours, the osmolality goes up and then to up to as high as 1000 to 1200 milliosmoles per kg. Now, this is what you call as a normal response. Now, if the person has nephrogenic DI, then there is no change in urine osmolality whatsoever. Even if you deprive the person, the urine osmolality is really going to remain less than 300 almost always. So in patients with primary polydipsia, okay, the compulsive water drinkers, the moment you deprive them of water, automatically the value becomes more than 800. Okay, so this is one way to differentiate. The moment you deprive them of water and the osmolality goes up, that means probably the patient is drinking a lot of water compulsively. That is primary polydipsia. So in nephrogenic and neurogenic DI, in both, once you start water deprivation, still the urine osmolalities are going to be really low. And how to differentiate between these two? You administer DDAVP or vasopressin. So pitressin, you can give either 10 mics intranasally in infants and 20 mics in children, or another protocol is to give vasopressin as 5 units per meter square subcutaneously, and then over the next few hours, you try and see what is happening to the urine osmolality. So if it was a neurogenic DI, wherein the ADH production is defective, the moment you give ADH externally, the osmolality is going to shoot up to more than 800. So clearly what was less than 300 after a given DDAVP, the osmolality rises promptly to more than 800. That means you're looking at neurogenic DI. However, in nephrogenic DI, we already know that already ADH is there. There is no problem in production of ADH, but it is the end organ resistance to ADH that is happening here in nephrogenic DI. So the osmolality of the urine remains virtually unchanged. What was less than 300, despite fluid deprivation, continues to be less than 300 even after giving desmopressin. So a value which is less than 110% change suggests that it is nephrogenic DI. In clinical practice, many times we get some values which are in between, which suggest that it is partial component of either central or nephrogenic DI. So now this is the basic mechanism for doing water deprivation tests. So I conclude here by saying that kidneys play an important role in acid-base, electrolyte, and water balance. A proper understanding of the basic tubular functions, like we just saw, will help us in correct phenotyping of most patients with the clinical setting. And I would be happy to take if there are any questions. Thank you. These are my references.
Thank you, Sudarshan, for that excellent overview of applied renal physiology. Now we will move on to case-based discussion. Dr. Georgie, are you ready? Meanwhile, Georgie is sharing his screen. The two moderators for today's talk, Professor Susan Uthup and Dr. Indra Agrawal. I welcome you all, both, ma'am. I'll now invite Professor Susan Uthup, who is currently the president of Indian Society of Pediatric Nephrology, to start the talk and say a few words about this initiative.
Thank you, Jitendra. It is indeed a great pleasure and a proud moment for the Indian Society of Pediatric Nephrology that we are able to conduct this program, which is going to be a wonderful one, academically a great event, which is going to help the postgraduate students in pediatrics across the country, as well as the pediatric nephrologists and pediatric nephrology trainees to have a good grasp. And we are starting from the basics. And today, Dr. Sudarshan has already given us a nice presentation on the entire renal physiology with applied aspects also incorporated. And we all know that the renal tubule and the glomerular functions and everything is remaining as a wonder. It is a wonder world. And the more you read it, the more confused you become. And so I will tell the attendees, whoever is there, that you don't have to feel totally lost after hearing this session, because we will be making you understand these intricacies more and more as we move through these 32 sessions. And we have actually very dynamic, very energetic, enthusiastic young faculty members who will be taking you through this journey throughout. And Dr. Indra, I want you to also to say some few words before Georgie's will start. Over to Dr. Indra.
Just good evening, everybody, and it's wonderful to be part of this session. I think we've been all given a very good introduction on the idea behind these series of lectures, and I can see that it's going to be extremely useful to all these our residents and postgraduates. And I don't want to waste too much time, but just to say that Sudarshan has really covered the session on at least the important aspects of physiology and all the, the basic electrolytes and, their sites of absorption. But how do we actually use this in our clinical practice? I think that is what is more important, because as Susan said, a lot of this we read several times, we forget it, and then sometimes we wonder, why are we trying to remember all this? Now, through these case-based discussions, I hope Georgie will bring out the importance of understanding this physiology and how do we apply it in our clinical practice? How do we use this knowledge to diagnose different diseases? So I'm sure it's a very useful session ahead. And without further ado, I shall hand over to Georgie. Thank you.
Good evening, everyone. My slide is visible and my voice is audible. Can I get a confirmation, please?
Yes, slide is visible.
Right. All right. Thank you for ISPN for providing this excellent initiative. I'm going directly into the applied renal physiology case-based discussions. So parallel to Dr. Sudarshan's presentation, I would be covering some of the topics that he has covered. A few, one or two topics which were not mainly the purview of his discussion, but however pertaining to renal tubular physiology and the general understanding of renal diseases for especially at the postgraduate level, and some topics which may not be covered, I will be telling. So the outline of my presentation would be in this route. In view of shortage of time, I will be confining myself to 5 of these topics. However, in the upcoming sessions, you can see the other topics which are not being covered by my talk for today. However, as Professor Baga already mentioned, you should always go back and read the current edition of these standard textbooks, Indian as well as international. And these are a few online reliable sources for information for pediatric nephrology specifically, which all the residents and fellows or postgraduates will find it very useful, and they are from trustworthy sources and explained in very simple language these complicated topics. So I would be requiring an interactive session from the participants. So many of my topics have questions for which some answers you can put in the chat box. Going to the first case scenario, we have a 5-year-old male child who has recurrent urinary tract infections in the past with bilateral scarred kidneys identified on a DMSA scan, that is a nuclear medicine scan. So he's currently asymptomatic for the last 6 months. He does not have any acute complaints, and he has come to you. He was brought to you by parents for his evaluation. On examination, you find his height was 100 centimeter, blood pressure is 106/64 millimeter mercury, and serum creatinine over the period of last 6 months, we have about 2-3 values in the range of 0.6 milligram per deciliter. Which among the following statements below is correct? 1, he has acute kidney injury stage 1. 2, he has chronic kidney disease. 3, he has end-stage kidney disease. And 4, his kidney functions are absolutely normal. I would wait for about 20 seconds, 15 seconds for some answers in the chat box if all of you are listening. Okay, I'm already getting some answers. B, D, B, A. All right. Okay, so yes, so I'm getting all the answers except C. So I think most of you are thinking in the right direction, though the thoughts would require some refinement. I would help clarify the answer. So in this scenario, what are we looking at? We are looking at what we call is glomerular function. Dr. Sudarshan in detail about glomerular function and progressed on to tubular function. We should know and understand that the primary or predominant function of the kidney is glomerular filtration that is being handled. And if glomerular function is only normal, then only we can go proceed with evaluation of tubular function, which I will come to in the subsequent slides. So as defined by KDIGO, chronic kidney disease is defined by the abnormality in kidney structure or function, which has been present for more than 3 months with implications of health. And these are further classified based on cause, GFR category, and albuminuria category. So this patient has bilateral scarred kidneys. That means there's an acquired abnormality which has been persistent because scars are usually permanent in the kidney, and there's a persistent for more than 3 months, and an abnormality in the kidney structure. So that equals CKD. So the correct answer in this patient would be he has chronic kidney disease. Then when we want to define the staging of the kidney disease, so we calculate the estimated glomerular filtration rate by the modified Schwartz formula, and they which gets us about a 69 ml per minute per 1.73 meters square of eGFR, which gives us a CKD stage 2. So he has chronic kidney disease stage 2. So going back to the question, why does he not have acute kidney injury? These values are persistent over a period of 6 months. So it is not an acute event. He has end-stage kidney disease. No, he is not chronic kidney disease stage 5 with dialysis. His kidney functions are normal. So some people may have given the answer. It is entirely okay to think like that. However, when we see the patient with an anatomical abnormality, always there is chronic kidney disease. The connotations of having chronic kidney disease is very important for the prognosis of the child. So we should not assume that his kidney functions are normal. Another confounding factor is that the creatinine is 0.6. Why do you say 0.6 is abnormal? So when we look at the normal values of creatinine in children, so you can see the 2008 paper has given the normal values of children, the median with the upper limits. Even if you draw the upper limits, if you look at this graph, you can see that the upper limit, the graph which the line which goes above the upper limit of 0.5 holds true till about 5.5 years. So any child under the age of 5.5, if you get a creatinine above 0.5, even if 0.6, look at a second time, evaluate his estimated GFR by the modified Schwartz formula. I hope it is clear, and this is very important for all and any sort of kidney disease in children. All right. So going on to the next slides, we have a 2-year-old male with polyuria, polydipsia since infancy, failure to thrive, bowing of legs, recurrent fast breathing, salt craving, without any history of recurrent pneumonia, diarrhea, oily stools, recurrent UTIs or blood transfusions, and a sibling with similar illness who passed away at the age of 3 years. On examination, he has significant failure, significant wasting and stunting with rackety grocery, open with features of rickets, without any organomegaly or pallor or edema. And on evaluation at the hospital, he is found to have a 1.5 liter urine output per day, which is quite significant. That is about 3.5 liters per meter square per day for the child. So laboratory investigations, this is a picture of the child. all of you, I'm sure, can very well see the rackety grocery, then the bowing of legs. And then on examination, his counts are so mentioned, normal. Creatinine is 0.2, which as we already saw in the previous slide, is absolutely normal. You can see the abnormal values. Please put in the chat box what are some of the abnormalities that you can find in the images. Along with that, one X-ray of this wrist is shown. So just put in few of the abnormalities that you can see in the evaluation. I will wait for about 15 seconds in the Q&A session. Hypokalemia, okay, everybody is noticing potassium of 2.8, definitely. Metabolic acidosis, rackety grocery, yes. Features of rickets. Excellent, raised alkaline phosphatase. Kindly answer in the kindly answer the question in the Q&A session, not in the chat box. Alkaline urine pH, exception. Alkaline urine pH, yes. It is not alkaline, but it is inappropriately high urine. It is 5.3. It is not alkaline urine pH, sorry. Low phosphate, yes, somebody has picked up a low phosphate. Excellent. So I would like to go to the next slide. Okay, thank you for your answers. So you can see this. This patient has growth failure with severe stunting, features of rickets, metabolic acidosis with normal anion gap, hypokalemia, hypophosphatemia. One keen-eyed person has pointed out 3 of phosphate, that is low. Yes, that is one I wanted to point out in this session. Urine pH was very low. So you see that normal anion gap metabolic acidosis with generalized proximal tubular dysfunction with low urine pH glucosuria. So this you are dealing with a proximal renal tubular dysfunction or proximal renal tubular acidosis. We have a session on renal tubular acidosis later, so I will not go into the detail. I would want to focus on one key element, which is hypophosphatemia or phosphaturia. So how would you proceed with the evaluation of phosphatemia or phosphaturia? Dr. Sudarshan has already alluded. One key thing I want to point out in this particular table is that the phosphate, the lower level limits of serum phosphate actually does not become 3 or the adult values by age 13 or 20 years. So see, smaller children do require quite a high requirement of phosphate for their bone growth. So the lower limit should be taken into consideration when you are interpreting values. These values are freely available. The references are given here. And also when you're interpreting any calcium value, do remember to correct the calcium for albumin levels. Okay, so phosphate levels, the lower limits and the actual levels and lower limits do reduce over time along with a concept called TMP-GFR. So what is this TMP-GFR? How do we know whether this low phosphate in this child is caused by either reduced intake or is it caused because of extreme renal wasting or leakage of phosphate from the kidney? Dr. Sudarshan has already alluded to. I would be reinforcing this in the next slide. So you do a timed urine collection in this patient. So you get a urinary creatinine and urinary phosphate. So all the urinary metabolites are usually referenced to serum creatinine because creatinine is being constantly excreted. So you do the fractional excretion of any solute. It's a standard formula that every one of you, I presume you knowing. So this fractional excretion of phosphate in this patient is found to be about 20%, which is high. Normally it should be, kidney should be reabsorbing 85% or more in this patient. So what does the kidney normally do? How is phosphate metabolism normally done? Phosphate is present in anything and everything that you eat except maybe, pure water, distilled water. Anything and everything with organic matter has phosphate in it, and phosphate is important for each and every cell in the body. So phosphate levels in the blood is maintained in constant levels by vitamin D, parathormone, calcitonin, and many other hormones which are present. And the kidney handles the major phosphate levels in the blood, maintaining a normative value between the influx and the output. Normally, when the body's levels of phosphate come down, kidney should frantically start to accumulate more and more phosphate. Do not let the phosphate leak in the urine. So there are some clinical conditions like renal tubular acidosis of the proximal variety affecting the proximal tubule, where major 80% of the phosphate, 80-90% of the phosphate handling takes place. If that is affected, kidney starts leaking phosphate even at lower thresholds. So I hope you are able to understand. I'm sure all of you have listened to this analogy of a bucket with a hole in the side when you are thinking of proximal RTA, so that how much ever water you put in the bucket, you cannot go above a certain limit. So that is the threshold at which the solute starts leaking in this situation. So we want to find out what is the threshold at which phosphate is leaking or in this patient. So we calculate the tubular reabsorption of phosphate, that is 80%. So in effect, kidney is unable to conserve phosphate during hypophosphatemia. You have Sudarshan already alluded to fractional excretion of sodium. When the body is hypovolemic, requires more sodium, it conserves 99% of the sodium, and less than 1% of the sodium is only excreted in the urine. Similar to that situation, when the body has low phosphate, the kidney tries to conserve enough phosphate so that very little is excreted. But in disease conditions like this, the reasons of which will be described in the further sessions, kidney is unable to conserve phosphate. So we have a serum phosphate and TRP values in our hand. So we have the Walton-Ridgway nomogram, which is obtained by phosphate infusion studies in about 100 patients. So you plot the actual plasma concentration of phosphate on the first axis, then you plot the TRP on the other axis, on the diagonal axis, and you join a line between them, and then you join the line to the other side, which will get you a 2.4 milligram per deciliter. So this effectively means kidney starts leaking phosphate after any value of 2.4. Below 2.4, kidney will maximally reabsorb kidney. Kidney does not have any capacity to hold on phosphate till it becomes normal 3.5 to 4.5 in this patient. So in this patient, kidney leaks phosphate at 2.4 and tubular threshold is, so that is what is causing the hypophosphatemia in this child. I hope it is clear. Please do this, use this nomogram, freely available anywhere online. You need to use it on regular practice to make yourself acquainted to it. So moving on to the next case, we have a child with polyuria, polydipsia, tetany, and seizures without any recurrent pneumonia or diarrhea. Again, all the negative history is mentioned significantly here, with a good calorie, proteins, calcium, and vitamin D with good sun exposure. We find the child is malnourished and also has prososign positive, but without any obvious features of rickets or hepatosplenomegaly. So what are we dealing with here? We are dealing with the polyuric polydipsic phenomenon with features of hypocalcemia. So how do we go about an evaluation? Again, we do the workup. First and foremost, you do the glomerular filtration. Yes, the glomerular filtration is normal, evidenced by the creatinine of 0.3. You find a really low calcium with a normal albumin, with normal vitamin D, PTH, and also along with that, you find the low magnesium. So an ultrasound shows bilateral nephrocalcinosis. I'm sure it is clearly evident to all the students. If if you have any doubt, please put in the chat box. We will be clearing it as and when we go. Okay, so the abnormalities in this patient are, you have hypocalcemia. However, the albumin levels are normal, so we don't need to correct it. So normal phosphate, vitamin D, alkaline phosphatase, high parathormone, which is appropriate for the hypocalcemia, and you also have hypomagnesemia. So we are focusing on with nephrocalcinosis with a normal eye evaluation. So we are focusing on evaluation of renal magnesium loss. So how do we evaluate for renal magnesium loss? Anybody just point out for a few seconds, how would you evaluate renal magnesium loss in this patient? I'll wait for about 15 seconds. How would you evaluate for renal magnesium loss? This follows the principles of any other solute loss in a patient. Okay, fractional excretion of magnesium, excellent. So audience is listening, excellent. So you have values of urine creatinine, magnesium, serum magnesium, and serum creatinine. So with that, you find the fractional excretion of magnesium, which is found to be 5.7%. So that is a normal would be less than 4%. Some book says 3%, and some book says 5%. That's okay. So anything more than 5% is definitely abnormal. So normal should be less than. So in this patient has renal magnesium wasting. Some disorders which have renal magnesium wasting are hypomagnesemia with secondary hypocalcemia, Edelman syndrome, FHHNC, which is Claudin 16 and 19 disorders, Yeast syndrome, and other variants. This is an extremely interesting topic if you are willing to read. If you read the the American Journal of Kidney Diseases has an excellent core curriculum on this topic. Please do find your time to read all the solute abnormalities from American Journal of Kidney Diseases core curriculum. Very useful and easy to understand. Okay, without we are going ahead. So in this patient mostly has a TRPM6 variant. Management includes nutritional rehabilitation, calcium, magnesium supplementation, and very high dose of magnesium may be required. Going on to case scenario 4. You have a child with frequently relapsing nephrotic syndrome with edema for 4 days, abdominal pain, abnormalities. So abdominal pain with the following investigations. Would anybody like to describe the abnormalities and the diagnosis in this patient? Polycythemia, very good. Somebody has mentioned pre-renal AKI with the creatinine of 0.1. The kidney functions are still normal, so you cannot define AKI in this patient. Okay, hyponatremia, high urea, dehydration, underfill theory. Okay. I think most of you are getting the point. Excellent. So you can always also see that there is a mild, there is hypoalbuminemia, hemoconcentration, and metabolic alkalosis in this patient. So you have features of hypovolemia, or we call what we call mesenteric ischemia in this patient. Also, please think about other causes of abdominal pain in this patient, which are mentioned here. So how do we establish intravascular dehydration? So some parameters, like Dr. Sudarshan has mentioned, are fractional excretion of sodium, fractional excretion of urea. Another important index I want to put in your attention is urinary potassium index. So this means when there is hypovolemia, this activation of renin-angiotensin-aldosterone system, there is sodium retention with potassium excretion. So as you can see in the formula, even there is sodium retention with the potassium excretion, this ratio becomes high when the normal is less than 0.6. So this indicates activation of renin-angiotensin-aldosterone system secondary to hypovolemia. Also, other parameters which can be used are fractional excretion of sodium, urea, uric acid, and urea creatinine ratio. All of these you will be able to understand from standard textbooks. Okay, coming to the last scenario in my topic. So a 2-year-old male with polyuria, polydipsia for a year, 2 episodes of severe dehydration requiring admission, 2 episodes of seizures yesterday without any other negative history as mentioned here, with 2 family members having similar problems with significant wasting and stunting, with doughy abdomen, with the normal blood pressure without any other abnormalities. So these are the abnormalities, the blood results of the patient. Again, I would like to get your opinion on this. Okay. Okay, hyponatremia, low urine osmolarity, diabetes insipidus, hyponatremia. Okay, excellent. So we can see that clinically and biochemically, this patient has hyponatremic dehydration. So with a very low urine osmolarity and a high serum osmolarity. So this is a condition of diabetes insipidus, which is an X-linked inheritance. And in this patient, true hyponatremic dehydration is present in the patient with normal renal functions and blood sugars. You know, they are also other things which we should consider while interpreting the osmolality. So low urine osmolality and low specific gravity, which indicates a diabetes insipidus. Does this patient require a water deprivation test? Now, right now he's in your emergency or in your ward. Does this patient require a water deprivation test to prove a diabetes insipidus? No. Okay. No. One more opinion. Okay. So with lack of time, I would proceed. So all of you are right. So this patient does not require water deprivation test currently, because patient is already showing features of significant clinical dehydration with high sodium, and this is like the targets of your water deprivation are already achieved. So when you consider a baseline osmolarity interpretation, so this will be your keys towards interpretation of osmolarity. I'm sure these things will be explained in detail in a subsequent presentation. So this is the last. So thank you for your attention. Any of your doubts, you can email me at this address. Thank you very much. This is just a primer for you. Please go back and read your standard textbooks as well as valid, reliable online references. This would be very useful for you. In case of any doubts, please feel free to contact any of us faculty. Thank you.
Georgie, it was a really wonderful collection of cases and nice discussion that we were having. And we are expecting some questions from the in the Q&A box, and let us keep answering them. So there is one question that has come: how to correct hypernatremia if there is no dehydration and need to restrict fluids in AKI? Georgie, can you go ahead with answering that question? Georgie or Sudarshan?
The question is how to correct hypernatremia if there is no dehydration and need to restrict fluids in AK. Normally, that scenario does not occur. Hypernatremia occurs usually with dehydration. I am not able to understand if your the question is if there is a scenario with severe dehydration and acute kidney injury, which is commonly seen in neonates, where they come with 190 of sodium and creatinine of 7.7. How do we go about it? There are a lot of methods which, in view of time constraint, it would be difficult to explain all of them. Definitely, peritoneal dialysis for small children or renal replacement therapy would be an important tool in correcting hypernatremia with acute kidney injury in such patients, or the extremely careful fluid infusions with extreme close monitoring of sodium and the renal functions would be another method. So there are different methods explained in textbooks and reviews. In case of AKI, definitely would be peritoneal dialysis may be required. Yes. Another
there are so
question.
many questions, coming up. Dr. Indra,
Yeah.
will you address the second question? And I think Sudarshan or Georgie, both of you.
I'm not able to see that question. I think
Yeah,
maybe
then-
Susan, you may ask it.
Yeah.
I'm not able to see that.
Yeah. Many children with nephrotic syndrome will come for control. They have concurrent chemo concentration indicating underfill, but are also found to have high BP, suggestive of overfill. So should we give a liberal fluid in this case or restrict fluid and give diuretics? Estimation of urinary indices becomes unreliable as most of these cases are on concomitant diuretics as well. So how will we proceed? Underfill versus overfill. How to diagnose when in an edematous nephrotic child? Sudarshan, do you want to take this question, or Georgie?
So this patient with urinary indices become unreliable as most of these patients are concurrent diuretics. That is a normal clinical scenario that we regularly see. However, when the patient came, as if you are say concurrent overhydration, so even if they have high blood pressure, it is what is of clinical importance here. We have on one hand, we have intravascular hypovolemia. On the other hand, you have high blood pressure. High blood pressure may be because of multiple factors, because of pain, anemia, anxiety of the patient. So many factors can be there in this scenario, which can indicate a high blood pressure. However, intravascular volume is of the prime importance. In patients with nephrotic syndrome, we have to value intravascular volume over any other features, because if you do not fill the intravascular volume, it actually becomes hypoperfusion to other tissues, which can have potentially very damaging or even fatal consequences. Thrombosis, shock, lot of other complications can happen. It is always good to do a proper evaluation. Clinical evaluation, simple clinical evaluation is only needed to give you a close indication of your underfill hypotension. The referees are cool, CRP, 2 seconds, tachycardia, it is underfill, whatever the other things are there in place. You do not need to bother about the other indices. If you can, well and good, do go ahead. But in clinical practice, we need to treat underfill as soon as possible. And many of the studies have mentioned nephrotic syndrome, 70 to 80%, please correct me if I'm wrong, or even more than that, higher numbers have underfill than overfill.
You are right. But one thing which we have to understand is we have to look at the creatinine also. and the urea. And that another question that is coming up is why we are telling pre-renal AKI in the next question. Actually, when the urea is disproportionately high and the creat is normal, as in case number 4, because of the decreased perfusion to the kidneys, the urea gets reabsorbed by the tubules, and that results in a disproportionate rise in urea, and the GFR remains normal. So such cases, again, underfill is definitely obvious, and you have to improve the intravascular volume. And another thing is the creat will be, if it is creatinine is abnormal in such cases, it indicates an established AKI. And in such cases, we have to be very careful in giving the volume expansion, and we have to be careful about the producing pulmonary edema. Georgie, you want to add something more? Sudarshan?
I think, can I say something? Can I say something? See, I think this creatinine may be also abnormally low because of the poor muscle mass. We have to keep that in mind. The child was quite malnourished. And because these children are also polyuric, so there will be some degree of dehydration anyway. So one has to actually look at the whole scenario. It's not just looking at what is the urea and what is the creatinine. You have to actually understand the whole clinical picture and then take a call on what your next action would be. So I hope they've understood that. That is the fallacy with creatinine, isn't it?
Yeah. Then another question that has come up is how to correct severe hypernatremic dehydration with ongoing losses in a child with failure to thrive by being careful about volume overloading.
I think like some of these questions, about particular topics will be discussed in it. We have like specific sessions for dysnatremias and dyskalemias as well as AKI.
Yeah, that is some revision will be
so maybe
going on
briefly,
in the subsequent sessions.
Yeah.
May I request us to do the rest of the Q&A by typing the answers into the chat in the Q&A, and we could move on to doing the post test because we have done 1.5 hours of our session already, and the participants would like to go back to that. Thank you. So should we hand this over? Thank you, ma'am. Thank you, Indra ma'am, and thank you, Susan ma'am, for doing this very masterly. And we'll move on now to the post test. Jitendra, is that okay? Shall we hand it over to Pinky then?
Yes, ma'am.
Pinky, over to you. And Jitendra, would you just discuss the questions as they come along? Thank you.
Yes, ma'am. So, ma'am, can we...
Pinky, could you just verbally tell the instructions to the delegates? Yeah, as you project your screen and put the link in the chat window for them.
Yes, sir. I'm just sharing you, ma'am. I'm just sharing you the link in the chat section. Please have a look. And I'm sharing you my screen.
Request all delegates to go to the link that is on the chat window and keep looking at the screen here. You can see how the delegates are beginning to join that. You will keep seeing, you will not be able to join further till we initiate the quiz.
So I request you to all of you, please click on the link and paste your, put your email ID.
Can we begin then? Can we begin with the quiz?
Okay. So, am I audible?
Yes, you are.
So, ma'am, I hope everyone is participating in this QA session.
Yes, I think a few people are getting
Yes.
confused because they are not able to proceed further.
Okay,
So
okay.
I think we should begin.
But it's showing only 140, 150 people are like joining probably. I don't know. The
Okay.
number in the
Mhm, mhm.
Kahoot, this is
Yes.
146
140.
and total participants are 230.
So request everyone to click on the link, go on to the Kahoot link and put in your name and email ID. Is that the two things that they ask for, Pinky?
Yes, yes,
That-
ma'am. You are
Just
right.
the name
ma'am.
and email ID.
Just
And then
write
wait,
their name and email
wait,
ID.
you will be able to click and go to the quiz as soon as we open it. But we are just waiting for all delegates to get there. The numbers are still at 142. It's okay. I mean, we would want everyone to please participate. Thank you. We'll wait another 30 seconds and then begin.
Yes.
Pinky, is it possible for you to share the Kahoot link again in the chat box one last time?
Yes.
And continue to admit people during
Yes.
the quiz. Yeah.
Yes, ma'am.
Yeah.
I'll do.
So delegates, you have to wait. You will not be able to click on anything after entering your name and email ID till we open the quiz. And you will be able to see on the screen that the quiz is open. At that time, you will also move.
Yeah.
Yeah.
Again, I'm sharing you the link.
I
everyone
hope there is
smiling.
like no limitation of maximum number of people who can join because this number is not going beyond 145.
Yeah.
Mhm. Please make sure everyone is able to join the link. I hope so.
Jitendra, I think they can continue to join once the quiz is started. We should begin. We are at 8:35.
Yeah, ma'am. So, Pinky, I think you should start the quiz.
Okay. Okay, sir. Yeah.
Jitendra, it would be good to just read the question or is that okay? Yeah. Each
think
question gets 15 seconds and a countdown. Yeah.
Let them focus on answering.
And should we go the next?
Yeah.
Okay, so these are your top 5 people.
Next.
You can just at the time the answer displays, just speak about it a bit. Yeah.
Sudarshan?
Okay, yeah. So tubular secretion, as we saw, creatinine gets secreted also through the tubules. So these are some of the commonly used drugs which inhibit the tubular secretion. So cimetidine, septrin, and probenecid are well known to inhibit the secretion of creatinine. So a patient who's concomitantly on cimetidine or septrin, you will know that the creatinine levels go up. It is not probably because of just kidney injury, but because tubular secretion is not happening. That's why. And among this, ranitidine does not have. So that is the answer for this question.
Next question, please. Great going. Next question.
Yeah, so we just saw that in tubuloglomerular feedback, whenever there's increased distal delivery, the body is now trying to conserve, thinking that there is so much loss. So it will send feedback to the afferent arteriole, leading to its constriction so that the GFR, the glomerular filtration overall decreases. So the answer A is the correct answer for this.
Next question.
As we have seen transtubular potassium gradient, you're trying to see the urine upon serum potassium, and then you're indexing it to osmolarity because water gets reabsorbed distal to this. So to correct for that, we are indexing with serum upon urine osmolarity. So the C option is correct.
Okay, so this is not nephrogenic DI because you see that the osmolality has increased already. So following water deprivation, only if the osmolality is increased, probably this is compulsive water drinking or primary polydipsia. If it were central DI, this change would happen only after we have given a dose of desmopressin or pitressin. Okay, so the correct answer is primary polydipsia. So unlike most of the ions like sodium, potassium, most of which get maximally reabsorbed in the proximal tubule, magnesium is one ion which gets maximally reabsorbed in the thick ascending limb of loop of Henle. So the loop of Henle is the correct answer here. So maximum ammonogenesis happens in the proximal convoluted tubule. So if you see, that is also one reason why PCT has dense brush borders and so much mitochondria also, because there's so much active mechanisms happening, and ammonogenesis is maximum in the PCT. This was pretty straightforward. So the early DCT, beyond the early DCT is when the ADSN or the aldosterone sensitive distal nephron happens. So DCT1 is the early DCT and DCT2 is the distal part, which is the late DCT. So late DCT and downstream. So late DCT connecting tubule, cortical and medullary collecting ducts are the ones which are typically aldosterone sensitive. Okay, so I know this is a tough one. We have all heard about Claudin 16 and 19 in magnesium reabsorption. Now, Claudin 1 and 2 have all been now identified, and Claudin 2 is the protein which has been identified to have this property in the proximal convoluted tubule. Okay, so rhesus B glycoproteins are new proteins which have been identified. We have B and C glycoproteins which have found a role in ammonia transport. They are present in the alpha intercalated cells, the ones which secrete acid. And it is here where the ammonia genesis happens through the alpha intercalated cells.
So would D-Man identify himself or herself? Should be him, I guess. And Nikita.
D-Man.
Okay, could you post in your real names and your affiliations, please, in the Q&A window? We'd